Good morning. We're about to start our Symposium 8 on infection control. So for those who want to move forward, if you might want to move forward still, there's still some vacant seats up front. So good morning. As we have heard several times over this last convention, over the last few days, these are times where we are dealing with dangerous bugs, multidrug resistant organisms, and emerging and re-emerging infections. This is imperative, therefore, for all of us who are healthcare practitioners, regardless of whether you're an ID practitioner, a general internist, family med practitioner. We all have to be active advocates of infection prevention and control, precisely because of the changing landscape in infectious diseases, as evidenced by the different topics we've had over the last 2 days. Therefore, it is such a privilege for us today to be able to hear from 3 distinguished speakers who will be able to hopefully give us some tools that we can use as healthcare practitioners in our areas of practice to be able to prevent infection and control infection and the spread of infection. No? We will be hearing from our speakers on topics on novel approaches to the prevention of catheter-related bloodstream infections. We will be hearing also about the who's and how's of infection control precautions in MDRO infections, and the prevention of surgical site infections. So I'm Dr. Catherine Colaiko. I'm the chair of this session. I'll turn you over to our co-chair, Dr. Thea Kahulao, to introduce our speakers. Thank you.
Okay, so good morning. I am here to introduce our 3 distinguished speakers for this morning's symposium. So we have 3 speakers who will give 3 lectures on infection control. Our first lecture will be entitled Novel Approaches to CLABSI Prevention. Our first speaker is Dr. Marion Priscilla A. Kwek. She is currently the chair of the HIV/AIDS Core Team Committee of the Perpetual Health Medical Center. She is the Assistant Training Officer of the Infectious Diseases Fellowship Program of the Makati Medical Center. She is also the chairman of the Infection Prevention and Control Committee and an active consultant as well of Asian Hospital and Medical Center, and an associate active consultant also at Makati Medical Center. So let us give a round of applause for Dr. Marion Priscilla Kwek. I'll introduce everyone na lang, okay, para dire-diretso na tayo. Our second speaker, who will be giving a lecture on the who's and how's of infection control precautions for MDROs, is currently the Vice President of the Philippine Hospital Infection Control Society, Incorporated. She is also the Secretary of the UP Society of Infectious Diseases, or the UPSIDA. She is an Assistant Professor 5 of the Department of Medical Microbiology, College of Public Health, UP Manila, and a Clinical Associate Professor, Section of Infectious Diseases, Department of Medicine, UP-PGH. So she's none other than Dr. Evalyn A. Roxas, MD. And our last speaker, who will be giving a lecture on preventing surgical site infections, is an Associate Professor 4 and Consultant of the Department of Surgery, UP College of Medicine. She is also the chair of the Department of Outpatient Services of the Philippine General Hospital and the founding president of the Philippine Surgical Infection Society. Our lecturer would be Dr. Esther A. Saguil, MD. So let us give a round of applause for all our speakers this afternoon. This morning, rather. So let us call Dr. Kwek to give her lecture.
Okay, good morning, and thank you to the organizing committee for this invite. A lot of what we will be hearing today is something that's not really that novel, but I will include several data on newer interventions we can do in terms of improving our compliance to the bundles. So my topic today is targeting zero CLABSI, and I have no relevant disclosures relating to this topic. So this would be the outline of my talk. So as an introduction, we know that central venous catheters, or CVAD, central venous access devices, central lines, these are devices that are used to administer fluids, medications, blood and blood products, or parenteral nutrition. And we know that with every infection that occurs, there is usually an associated increase in mortality and, of course, increase in the cost of healthcare. From 2008 to 2013, according to the CDC, with the efforts of infection preventionists, there has been a 46% decrease in CLABSIs in hospitals across the United States. And there's data to show that zero CLABSI is really very much attainable. So how do we get central line infections? And these are associated with several mechanisms, whether it's contamination of the CVCs by endogenous microorganisms from skin, or extrinsic contamination from healthcare workers' hands or contaminated disinfectants. We also look at other factors in terms of contamination of our hubs, contamination of the infusate, as well as development of biofilms within the catheter. Okay, so generally for biofilm development, this is what makes catheters or other devices in general prone to developing infection, which is why sterility at the time of insertion and to every handling is important, because once a biofilm formation sets in, it's very difficult to control infection from setting in. Okay. And these are different determinants of infection risk. We all know this. So we have intrinsic risk factors. These are generally non-modifiable. We can't do anything about the patient's age, underlying diseases, or sex. So there has been data to show that the increase in age is associated with higher risk of infections. And this is actually seen also in our data in our institution, where majority of our patients with central line infections are from the ages 60 and above. And then, of course, there are these extrinsic risk factors. So these are the ones that we can modify and we can address. Anywhere from prolonged hospitalization before CVC insertion, the presence of multiple catheters, parenteral nutrition, the site where we inserted the line is very important, colonization of bacteria at the insertion site, multi-lumen catheters. The more lumens you have, the higher the risk for infection, and the lack of barriers, and so on. So this is some data from our institution. So on the average, for those of our patients, we had, I think, this is 2018 data, we had a problem with CLABSI in our facility. So on the average, the time from central line insertion to date of infection onset is on the average 22 days. But the immediate time, at least for our data, is around 2 weeks or 15 days. And we've noticed that there are cases wherein the central line stays in place for as long as 63 days. We also looked at the different factors as mentioned earlier. We noted that there was higher incidence of central line infections for those who had their lines inserted in the critical care units compared to those inserted in a sterile facility like the perioperative services. We had a higher rate of infection depending on the type of access. The non-tunneled would have higher risk of infection. And for the multi-lumen CVCs, most of our patients on triple or double lumen catheters had the highest infection compared to single lumen. So what's very important when we had our problem is the development of a specialized team. So this is multidisciplinary. It's hard to implement policies when you don't have the interventionist on your side. So it's very important that we collaborate with the vascular surgeons or the vascular med physicians or the intensivists in our intensive care units, because they are the ones who will be doing the insertion. We're not the ones doing the insertion. I personally don't know how to insert an IJ cath. And of course, we have your infection preventionists. And based on data, and actually this is part of nursing quality indicators. So our nurses are very important, the bedside, in addition to our infection control nurses. So CLABSI prevention focuses on interventions from insertion, maintenance, and removal. And we know, I'm sure we are all familiar with the CLABSI bundles, and we have bundles both from the central line insertion and for the central line maintenance bundles. So I just ran down the usual elements of CLABSI prevention, and this would include your hand hygiene and aseptic technique, your MAXIMAL barriers, optimal catheter site selection, use of chlorhexidine as disinfectant, And for central maintenance, more so review of line necessity and regular administration set change. So we all know this, very important. I'm sure this is something that you listen to with every lecture. Hand hygiene is very important. The one who does it, anyone who accesses the line should perform it. Always when doing handling of care or even prior to insertion at point of care. So it's very important that your hand hygiene facilities are very close to the bedside. Of course, to prevent infection. And it's recommended to use 70% alcohol plus 2% chlorhexidine gluconate for hand hygiene. And for hand washing, of course, your soap. And very important to remove jewelry. Now, for maximal barrier precautions during insertion, we should follow all 5 barriers: the sterile gloves, gown, cap mask, and the large sterile drape, similar to an OR setup, not just for the proceduralist, but also for the assist. More often, what we usually see is the one who inserts is wearing the cap and mask and all the other barriers, but the one assisting him is not wearing anything to protect, just a mask maybe. So this is the ideal setup of how a preparation for central line insertion should be. And then, of course, during maintenance, you wear clean gloves when accessing or administrating the central line tubes and ports. However, when you are changing the dressing, it's important to use the sterile gloves when accessing the dressing itself. And of course, for site selection, we need not discuss this in depth. We know that we try to avoid the femoral access as much as possible. So for the type of central lines, it's very important that the one who will insert it should anticipate the potential need for how much or how little lumen is required, considering the possible deterioration of the patient. So the number of lumens, will this patient be receiving TPN or lipid-containing solution, which usually requires its own separate lumen dedicated for that, and of course the duration of central line placement. And of course, the different catheter types, they each have their own advantages and disadvantages. But this has to be balanced with the potentials for risk also. And then also it's recommended that we use ultrasound to visualize where to put in the catheters during insertion to reduce the risk of cannulation failure. Okay, let's go to chlorhexidine. We all know that this chlorhexidine has a lot of data already in terms of central line prevention. It's used both for skin disinfection prior to insertion, but also when you access the central lines themselves. And the reason why chlorhexidine is preferred is because of, not only because of its bactericidal activity, but rather the time or the sustained antimicrobial activity. In terms of dressing, we have to change the dressings regularly or monitor our patients daily in terms of its access. Is your sterile transparent dressing or semi-permeable, in which case you don't have to change it so often. You can monitor if your barrier or dressing is non-intact already, and that's the time that you change it. For those with active bleeding or moisture production, you change it when you're with the sterile gauze, and you change it every 2 days or sooner, depending on whether your inspection shows that it's not good anymore. So these are some examples of what a non-intact dressing is. So it's really important for the one doing their rounds or audits to really look at how the central lines are. If you'd notice, it's no longer intact. The insertion site is already open, and then the sterile non-permeable dressing is already open. And these are also some of other photos that we have found. Now, in our hospital, when we implemented our interventions in terms of CLABSI reduction, we started, initially it was just a policy, but you know, as in other hospitals, it's kind of hard to implement the policies without the proceduralist involved or on your team. So we had a multidisciplinary project team collaboration involving all other stakeholders, as well as the ones who are preparing the sterile packs. We involved the OR team because when one of the interventions is for you to promote chlorhexidine for the use of the surgeons, you should have it available to them, and they have no other option or nothing else to use. So in their sterile pack, we already have a set for central line. All the things they need are there, and the chlorhexidine is already there, so they have no choice but to use it. And when we started using chlorhexidine preparation, this was included in our cart, there was marked decrease in our CLABSI rates in the ICU. Okay, so of course, very important to stress hub disinfection. Sometimes nurses are in a hurry. We know that we are understaffed. So I think that's a problem for most hospitals. So it's very important to stress that you have to scrub the hub. And yes, every second counts. It's recommended to scrub the hub for at least 15 seconds. And this is a picture showing what the port hubs appear to be when you disinfect for no prep up to 15 seconds. So you'd notice there's better disinfection with a 15-second prep. And there are available disinfectant caps that are impregnated with chlorhexidine. And of course, line necessity review. I'll just move forward because we're running out of time. Administration sets. Changing is dictated depending on what the infusion is. Of course, if you're using blood and blood products, you have to change the infusion sets every bag change or with every blood product. And for those containing propofol infusions, you change it when the vial is changed and so on. Okay. So there are other interventions that we have looked at. So there are data to suggest that having a compliance coach who audits central line maintenance and provides immediate feedback and education in a non-punitive manner is very effective. And they have shown that there was an increase in the compliance of the staff when they started instituting this compliance coach that provides immediate feedback. Although this might be a challenge in the settings where you have minimal staff to do this auditing real time. And then there are other data to show timely notification. So some institutions, there are some data that have shown that or develop a system where there is an automatic email sent already to the unit where the central line infection happened. And this promotes nursing leadership and engagement, and it also promotes ownership of this infection. More often than not in centers, alam ko marami sa atin has experienced this. Every time there's an infection, laging tinuturo na lang si infection control. But actually, we should make the unit accountable also, and they should be actively involved. Hindi yung when you do your fishbone analysis, RCAs, they should also be active participants because they know their unit better than we do. And there are also data for leadership rounding. So this is a process where the leaders visit the workplace and discuss areas of excellence. And there is some data showing in another institution, this is another article I came up upon, when they instituted leadership line care rounds. So there is a team dedicated for central line care, and they are experts as well as leaders in their own departments. So this is when they instituted leadership line care rounds, and they noted, so the line, the CLABSI rates is the dotted line. So there was some decrease with the immediate intervention, and then for the different bars that you see, these are the compliance to the different components of the central line bundles, which increased. And then there are also digital solutions. So some authors have investigated the use of entertainment education YouTube videos focused on infection prevention. And they showed that the availability of these useful videos in relation to hand hygiene is evident. But it's clear that there are, of course, opportunities for improvement because they have noticed some variations in terms of how videos are done. And then there's also some data on automated alerts, especially for those on electronic medical records. There are automated alerts for central line removal. It's like a prompter. Kasi dito sa culture natin, nahihiya yung mga nurses to call the attention of the physician, doc. The line has been there for so long. Do we still need the central line? And as we mentioned earlier, line necessity review is very important. So in some centers, they have developed automated alerts for this. And as I mentioned, automated email processes that send providers notifications when they do get CLABSIs. Now, I put question mark in the mandatory public reporting because although we report our infection rates to Department of Health, it's actually not public. But in the US, there have been federal laws that mandate centers to report and make it public in terms of reporting of their infection rates. And mandatory reporting requirements may spark hospitals to turn to proven infection control methods. And of course, there also has been some federal regulatory programs on reimbursement that has been done a long while back in the US. It's still going on. Wherein, when a patient develops central line infections or any other healthcare-associated infections for that matter, the hospital is not reimbursed by their Medicare or Medicaid or Medicare, and they are forbidden to charge this excess cost to the patient. And this could be a good incentive also for some facilities, but in terms of applicability in our setting, I don't quite know how to go about it yet. So it's very important always when you are presenting your data to the stakeholders in your hospital to also present patient outcomes. And in one facility that I'm involved in, these are our CLABSI cases, and we showed our physicians, we showed our nurses the data that we have, and 64% of our CLABSI cases expired, although not all of them are directly related to central line infections, but we know that having an infection in an already sick patient is not helpful. So in our facility, there is a 5 times increased risk of poor outcome for those who are on central line who develop central line infections. And I think that's what's very important. We have to be monitoring our patient outcomes. Thank you. So of course, we know stop CLABSI, and it all starts with you.
Thank you very much, Dr. Kwek. Now we move on to our next speaker, Dr. Evalyn Roxas.
So thank you very much to the organizing committee of the 40th PISMID Annual Convention for inviting me and for having me have this talk. So sorry for that. So I will be discussing the who's and how's of infection control precautions for MDROs. So for this session, here are my objectives: to review the transmission of MDROs and discuss the updates on the recommendations for infection control precautions for MDROs. Particularly, I'll present a recent study which tackles the topic elimination of contact precautions for MRSA and VRE. As we all know, MDRO pertains to multi-drug resistant organisms and is defined as microorganisms, predominantly bacteria, because there are MDROs among fungi and viruses, but predominantly bacteria, resistant to at least one agent in 3 or more antimicrobial categories. Although most of the MDROs describe resistance to only one agent, such as methicillin-resistant Staph aureus, these pathogens are frequently resistant to most available antimicrobial agents. MDR organisms as contrast to XDR, so we also have XDR, or extremely drug-resistant organism, which pertains to non-susceptibility to at least one agent in all but two or fewer antimicrobial categories. So meaning microorganisms or bacterial isolates which is or remain susceptible only to one or two categories of antimicrobials. And lastly, we also have pan-drug resistant organisms or organisms with non-susceptibility to all agents in all antimicrobial categories. As we all know, MDRs are associated to higher risk of death in patients infected with resistant strains, as shown in this World Health Organization figure. So what are the risk factors for MDROs? You have elderly, immunocompromised patients, an existing severe illness, so underlying disease or condition, previous prolonged antibiotic use, having medical devices, and take note, repeated contact with healthcare system or multiple hospitalization and an extended hospitalization are considered as risk factors for acquiring MDROs. Also, previous colonization with MDRO. So what are the different multidrug resistant organisms? So I'll just mentioning the most common MDROs. We have your ESBL or your extended spectrum beta-lactamase producing Enterobacteriaceae, wherein the threat is serious with the incidence and the death associated, as well as the cost associated for having this kind of infection. You also have your multidrug resistant Pseudomonas. Just like ESBL, the threat is serious also with Pseudomonas aeruginosa MDRO isolates, with that incidence and mortality associated to it. Acinetobacter baumannii, as compared to the first two, has a threat with a very serious level, meaning, very serious level, meaning it requires a more urgent concern as compared to MDR Pseudomonas and ESBL. Carbapenem-resistant Enterobacteriaceae, or CRE, the threat here is extremely serious, and of all the four, so this requires the most urgent concern. So other MDROs, you also have your methicillin-resistant Staph aureus. So we have an increasing incidence now of MRSA associated also with high mortality and high associated cost. And then VRE, or your vancomycin-resistant enterococci. So these are microorganisms or gram-positive organisms that have become resistant to it's supposed to be a drug of choice, which is vancomycin. Clostridium difficile, strictly speaking, is not considered as a resistant drug. However, it is somehow categorized under MDRO because it is treated like an MDRO because of the similarity in its transmission. So it is common sequelae of prolonged use of broad-spectrum antibiotic manifested with toxin-mediated intestinal wall infection. So it also entails high mortality and cost, but take note, a simple hand hygiene is very important in the prevention of Clostridium difficile. So how are these MDROs transmitted? So they say that MDRO transmission is in our hands. So it's in your hands because our hands can contain this MRSA, VREs, ESBL, and CRE, and it is one of the established mode of transmission of these multidrug-resistant organisms. So from patient to patient, via hands of healthcare workers, by direct contact with the organism when the patient has an open wound, or another established mode of transmission is transfer from contaminated environment or the reusable medical equipment or your RMEs to a compromised patient. So the best way to prevent MDRO infection is to prevent its transmission. And the two most powerful ways to prevent transmission are the following. So you have proper hand hygiene. So pasensya na po paulit-ulit. But it is very important. Cleaning hands appropriately is an established powerful way to prevent transmission, as well as cleaning reusable medical equipment or your RMEs before and after each patient. So we all know that environment can act as a reservoir for infectious organisms. Some organisms can survive or even thrive on environmental services for months if not properly cleaned. For example, your E. coli and your Pseudomonas can persist up to 16 months, your MRSA up to 9 to 10 months, TB for up to 5 months, and VRE up to 4 months. So proper cleaning and disinfecting is essential to reduce transmission and eventually infection. So most frequently contaminated reusable medical equipments include your pulse oximeter, ECG leads, glucometers, and your BP cuffs. Thus, it is vitally important that all of these RMEs be cleaned before and after each patient to prevent MDRO transmission. Smooth surfaces in the environment obviously requires less friction to adequately clean, like your tabletop telephones, as compared to your rough surfaces in the environment, which definitely will require more friction to adequately clean. So as I've mentioned, the most common RMEs, your ECG leads or pulse oximeters, will require more intensive cleaning as compared to the smooth surfaces. So who is responsible for preventing the transmission of MDRO? So the WHO. So there is no silver bullet, so there's no single person that can prevent this transmission. Success depends on having dedicated and knowledgeable teams of healthcare professionals who are willing to persist for years to control MDRO. So all infection prevention control practitioners know this, that in IPC we need to be persistent so that our program will be successful. Eradication and control of MDROs frequently requires periodic reassessment and the addition of new and more stringent interventions over time, and might require a median of 7 to 8 different interventions done concurrently or sequentially. So the CDC released these guidelines for reducing MDROs. So there are 7 steps in the control of MDROs according to CDC, and these are the following. So you have administrative monitoring, MDRO education, judicious antimicrobial use, doing antimicrobial surveillance. Take note that infection control precaution to prevent transmission is an established guideline for reducing MDROs, as well as environmental measures and decolonization. So let's go to step 1. So administrative support, implementing system changes to ensure prompt and effective communication of MDRO conditions. So I believe some institutions have this modern technology already of having an electronic medical records which show that this patient is an MDRO patient and that require a contact precaution for its isolation precaution. So it's one of the elements to control multidrug resistant organisms, having general policy, surveillance, and reporting. So hospitals should have a list of target MDROs. So the most common MDROs should be, you should have a list of that. And in some institutions, so it varies, so it depends on your own institution. Some institutions might include other organisms like Burkholderia cepacia. So hospitals should have a surveillance program to monitor the incidence of these MDROs, participate in regional antimicrobial resistance prevention programs, and should report these MDROs. The following are reportable pathogens. So whenever our institution have these isolates, this should be reported to the Antimicrobial Resistance Surveillance Program under RITM. Next, we have education, so facility-wide, unit-targeted education. Okay, you might include infection prevention control or the control of MDROs in your staff meetings, so like involvement of hand hygiene, understanding and creating a culture to support and promote desired behavior, and use of educational campaigns. So talking about hand hygiene, so this was previously discussed by Dr. Kwek a while ago, but just a question. So according to CDC, what percentage of healthcare-associated infections are caused by poor hand hygiene, so less than 1%, 20%, 40%, or 75%. So according to CDC, 40% of hospital-acquired infections can be attributed to poor hand hygiene. So the implication of this is that if only healthcare workers, all of us, will do proper hand hygiene, then we can avoid having 40% of healthcare-associated infections. So let us always remember that hand hygiene saves lives. So there should be persistent training and also feedback with hand hygiene. So these are just some of the posters, so we all know this, and the 5 moments of hand hygiene. So another prevention for MDRO is judicious use of antimicrobials. So for step 3, if you have equivalent to step 3, so this is summarized by AMS already, which we all know. So antimicrobial stewardship pertains to the judicious use of antimicrobials, so we all know this. So meet the core elements, presence of drug experts, so proper action, monitoring, and feedback as well. Next, you have MDRO surveillance or data mining. So most of the surveillance are done by having your own antibiograms in your hospital. So incidents based on culture results, targeted MDRO infection in specific populations or units. Some institutions have the capacity to do molecular typing of their MDRO isolates, so allowing detection of newly emerging pathogens, monitoring epidemiologic trends, and measuring the effectiveness of interventions. Next step for control of MDRO is infection control precautions. So you have barriers for patient care, cohorting, contact isolation, but what is the actual duration of contact isolation and the impact of contact precautions on patient care? So barriers for patient care, so donning of your PPE is as important as doffing of your PPE. So this is protection for barriers for patient care. You can also have signages which showed alert for MDRO, so strict hand hygiene and universal gloving. Some also advocate having inter-facility communication, wherein there is a system in place for identifying the infectious status and need for isolation prior to transfer. So this is not new, that in our hospitals we get MDRO cases sometimes not from our own hospital but from patients transferred from other hospitals. So there should be a system in identifying the infectious status of that particular patient, okay? So follow up pending labs whenever you don't have the definitive result yet, and system to inform the source location of MDROs. So I've mentioned a while ago several times contact precautions already. So just a review, contact precaution, it's under the expanded precaution, isolation precaution, and it is applicable for patients with known or suspected infections or that represent an increased risk for contact transmission, including colonization or infection with MDROs. So as we all know, contact precaution entails single occupancy rooms, so presence of alcohol-based hand rubs and sinks for hand hygiene. So with signages, use of isolation gowns and gloves. In long-term healthcare facilities, the physician or the team, IPC team, should make a decision balancing the patient placement on a case-by-case basis, so balancing infection risk and the potential adverse psychosocial impact on the infected or colonized patient. So when do you continue or discontinue your contact precaution? So this is the CDC guideline on when to discontinue contact precautions. So if you have MRSA cases, for example, so it's stated that you have to reculture the primary site if feasible, or the NARES, and if it's positive, then you keep the contact precaution. However, if it's negative, you don't discontinue it right away. You have to wait for 2 weeks and then reculture the sites and the NARES. And if it's still negative, again, you don't discontinue, but you wait for 2 weeks and reculture for the 3rd time. this one, and once you have the culture and it's still negative, so negative for all 3 sites, then that's the time that you call the IPC team and you ask permit if you can discontinue already the contact precautions. But several studies also showed that contact precautions are associated to the following. So fewer healthcare provider visits, shorter healthcare provider contact time, the lack of appropriate documentation. Sometimes you can experience delays in admission because you have to wait or to look for a single room wherein the patient can be admitted. And patients under contact precaution are said to exhibit increased anxiety kasi mag-isa lang po sa room sila. So increased anxiety, increased depression, and lower satisfaction compared to patients not in isolation. So studies also showed that there is an increased preventable adverse events, so non-infectious adverse events associated with contact precautions. So falls and trauma, so presence of pressure ulcers, post-operative hemorrhage, respiratory failure, medication administration errors, DVT, and pulmonary embolism. Thus, there is a question when to continue or discontinue contact precaution. So there is a very recent study which is entitled Non-Infectious Hospital Adverse Events Decline after the elimination of contact precautions for MRSA and VRE. So this was just published last July 2018. This is a retrospective, non-randomized, quasi-experimental study, and it aimed to evaluate the impact of possible discontinuation of contact precaution for endemic MRSA and VRE on hospital adverse events. So they compared the hospital adverse events before the implementation of the discontinuation of contact precaution, so 1 year before and 1 year after. And the study showed that non-infectious adverse events, particularly post-operative respiratory failure, hemorrhage, thrombosis, pressure ulcers, falls, and trauma decreased by 19% when contact precaution was discontinued without an effect in the infectious adverse events, even if you discontinue contact precaution. And particularly patients with MRSA and VRE showed the largest reduction with a 72% reduction compared from the pre to post intervention. So to further visualize this result, so this showed the adverse events, so the non-infectious and the infectious adverse events after the before contact precaution and after removal of contact precautions. As you can see, there is a decrease in the non-infectious adverse events without a change in the infectious adverse events. So even if you discontinued contact precaution already, there was no increase in the infectious adverse events. These figures showed that there was no significant change was observed for non-isolation patients who remained off contact precaution in both the pre and post-intervention periods. And comparing patients, particularly patients with MRSA and VRE, so there was a significant decline in the non-infectious adverse events, with 72% decline in the non-infectious adverse events when you discontinued contact precaution. Thus, the study concluded that after discontinuing contact precaution for endemic MRSA and VRE, the rate of non-infectious adverse events declined, especially for those who no longer require isolation, without significant difference in the infectious adverse events. Thus, the study somehow suggests that elimination of contact precaution may substantially reduce non-infectious adverse events. However, the study reported these limitations. So this study was performed at a single acute care hospital with single patient room, so single patient room, hindi ward. And they have very good hand hygiene programs, so the hand hygiene compliance in the hospital was greater than 90%. They also have good horizontal infection prevention strategies with application of near universal chlorhexidine in almost all patients. And the institution also has a robust quality control department. So all of these can possibly have an impact in the result of the study. So these are just some of the horizontal infection prevention controls. So it includes hand hygiene and use of chlorhexidine. So going back to the CDC guidelines of 7 steps of control for MDROs, so environmental measures are also vital. So we all know that the environment should be hostile to the multiplication of pathogens. So it should be clean, dry, exposed to light, and well ventilated so as not to support the growth of these multi-drug resistant organisms. So lastly, you have decolonization, so particularly applicable for MRSA cases, since some investigators have attempted to decolonize patients having VRE, but few have achieved success. So in summary, antimicrobial resistance is a global health concern, as we all know. There is an increasing drug resistance in common infections. Infection prevention and control measures such as hand hygiene and disinfecting RMEs or your reusable medical equipment between patients are key to continuing the spread, for containing the spread of drug-resistant bacteria. So by cleaning the right way, at the right time, with every patient, every time, we can all be part of the solution. So everyone has a role in infection control. And at this point, I would like to use this opportunity to invite everyone to the upcoming Philippine Hospital Infection Control Society 25th Annual Convention on May 23 to 24, 2019 at Crown Plaza Hotel. So we'll be celebrating the 25th anniversary of the society. So we have PILAC, so Fix at 25, or PILAC, Fix Ilaw sa Larangan ng Adham at Kalusugan. So we hope to see you there. Thank you.
So thank you very much, Dr. Rojas, for that very extensive lecture on infection prevention and control of MDROs. So we now move on to our next speaker, Dr. Esther Saguil.
Good morning, everyone. Paminsan-minsan may naliligaw na si Rohano sa ganitong mga convention. So thank you very much for the invitation to speak and share the surgical efforts in infection prevention as part, of course, of an institutional process. The objective of this talk, as I was told in the invitation, is to introduce the approaches to surgical infection prevention. My name is Esther Saguil. I'm a pediatric surgeon. Okay. So, masanay ako sa maliliit na tao kaysa sa malalaki. The main reason why I got involved in this infection prevention was I'm the committee chair of the Committee on Surgical Infections of the Philippine College of Surgeons since 2008. Unwilling initially, but later on champion na. Okay. So what is the burden of SSI? The problem with many surgeons is SSI is not considered preventable, but rather predictable. So they ask you, what are the rates? It's appendectomy. Oh, it's about 7% if it's a simple appendectomy. So if I get it, well, I'm the 7%. And if you have a ruptured appendicitis and you have infection, it's about 30% infection rate. So if your patient has the infection, an SSI, you just say, oh, I'm part of the 30%. Not realizing that in a single surgeon already has an infection rate of 90%. So this is very important when you see surgical data. So the global burden, about 2 to 5% globally will develop SSI, and it's actually the second most common HAI in hospitalized patients. Okay? The result is about 7 to 10 added hospital days, and the mortality can increase by 10%, can be about 10%. In the US, they have already actuarial evaluations that say that the cost of SSI per patient is about $3,000 to $10,000. So it's about half a million pesos per patient with SSI. That's so much. No, considering that PhilHealth only pays 24,000 pesos case rate package for appendicitis, whether it's simple or ruptured. Okay, so kulang pa ang binibigay ng PhilHealth para lang sa simple appendicitis. So definitely, we have to prevent infection to avoid further cost increase. In low and middle income countries, 1 in 10 patients will develop SSI. In sub-Saharan Africa, 20% of women who undergo cesarean sections have SSI. So medyo nakakagimbal, ano? And of course, you all know about the increased risk of antimicrobial resistance. So how do we define SSI? According to the Center for Disease Control, it's an infection that occurs in the wound within 30 days after an operation. And for implanted devices like hip replacements, vascular access devices, it's now considered 90 days. It came from 1 year. Okay. So how do you diagnose? They say that if you see purulent discharge, no, or there's organism growth from a discharge in a wound, or if the surgeon says that he has an SSI, very unlikely, or if there are symptoms and signs of erythema, so dolor, calor, rubor, prompting opening of an incision, that is a surgical site infection. The risk factors are, as with any infection, the host factors, extremes in age. A lot has been said about elderly, but even neonates are very high of, risk for infection. Obesity or malnutrition, so again, any extreme, okay, and a prolonged hospital stay. That's why we have been very, very adamant that patients should have at least just 1 day hospital stay preoperatively. And now the trend is towards ambulatory surgery because we want to limit exposure inside an hospital or healthcare facility. For the surgical environmental factors, the abdominal site, because it's the biggest area, is the most common area associated with surgical site infection. Wound classification, the duration, long surgeries and emergency surgeries have a higher risk for surgical infections. The same goes true with intraoperative contamination. The misuse or the not giving of prophylactic antibiotics, surgical technique, that's the surgeon's prerogative, and the surgical volume, and of course, the development of hematomas. So hemostasis is a very important component of surgery. For the microbial factors, I think most of you know this more than us. So it's the nasal carriage with MRSA, adherence and virulence of the inoculum. So what has been the evidence? In 2009, it was the first time that the CDC of the USA came out with evidence or guidelines regarding surgical site infection. But in 2012, the Institute of Healthcare Improvement, or the IHI, came out first with a guide to surgical site infection prevention, okay, SSI prevention. In 2014, the Royal College of Surgeons came out with their own predictions, with their own guidelines, and then in 2013, it was now the NICE, or the National Infection for Healthcare Excellence, came out with their own. So everybody wants to come out with their own guidelines. But the most important guidelines came out in 2016, when this was the most awaited guideline. The WHO came out with global guidelines in the prevention of SSIs, and they were based on systematic reviews and evidence and expert consensus-based. A lot of times there was not so much good evidence, grade A evidence, but a lot of them, the recommendations were consensus-based, depending on the opinions of experts in the international field. It also took into account, and they were very specific about this, they took into account resource availability, because the WHO works not just with first world countries, but also with Africa. So they had to make the balance. What is the most doable and achievable, taking into account availability of resources, but again, the overall aim was standardization of procedures. Last year, the CDC came out with guidelines, and again, not all the recommendations had very strong evidences. And we know very well that when it's the CDC that makes recommendations, when you do the accounting, when it comes to the math on the finances, they do come up with a little more expensive guidelines. So what do we do when we have these guidelines and you're in the Philippines, when the financial resources are so small and the annual DOH budget for every Filipino is only 50 pesos? It's very hard to just adopt guidelines, particularly coming from CDC. So I love the word to contextualize, which is just not really changing the recommendations, but depending on locally relevant information and strategies. So that's why we went into talks with the heads or presidents of the various surgical surgical societies to be able to come up with more meaningful, usable guidelines. We also work very closely with the ORNAP, or Nurses Association of the Philippines, and some of the FICNA and FICS to be able to come up with more acceptable local guidelines. And this was what we were able to come up with last year. December last year, we were able to publish the consensus recommendations on prevention of management of SIS in the Philippine setting. You can look into this. This is available online. So the strategies are nothing more than, they have to be divided into three: the preoperative, intraoperative, and postoperative factors, intrinsic patient factors, and extrinsic or procedural factors. For the preoperative factors, the normothermia, cessation of smoking, oxygen supplementation, and adequate circulating volume have conditional recommendations. I'm a pediatric surgeon. Ever since I started training, thermoregulation has always been a primary consideration. But the same is not true with adult surgeons. When we do abdominal peritoneal lavage, wash and wash until the return fork is clear, but water is dripping all over and the temperature of the patient is 35.5. Thankfully, it has been demonstrated that normothermia is important if you want to prevent surgical infections. Smoke and cessation because of vasoconstriction, oxygen supplementation to decrease bacterial proliferation, and of course, maintenance of adequate circulating volume. I love this infographic because all it says is, oh, the light doesn't work. Okay, but all it says is hypothermia, hypovolemia, and resultant low oxygen tension will promote the increase of bacteria in a wound, whereas normothermia, normal volume circulating, and hyperoxia in the perioperative period will limit the production or proliferation of bacteria. So for the second, how do we now improve resistance to infection? There are just two guidelines. One is maintenance of glucose control, not just in diabetics, but also in non-diabetics. The magic number in cardiac surgery used to be under 100, an HGT of 100. That was difficult. So now the current recommendation is maintenance of glycemic control under 200 milligrams per cent. As for nutritional upbuilding, again, both in the extremes of the spectrum, whether very obese or very malnourished, both will have negative consequences as far as SSIs are concerned. The third concern has to do with decreasing the bacterial load. And the asterisks are there to show that these are the ones with the strongest recommendations. The first recommendation is showering preoperatively. The magic time is the night before surgery. We agreed on 12 hours before surgery. But Filipinos like to bathe anyway, so it's not a problem. The contention was, are you going to use chlorhexidine or just soap and water? CDC said chlorhexidine. You know how much chlorhexidine is. WHO said soap and water is okay, so probably as long as it's not Tide or Ariel, you can do it. We now request patients and ask the nurses to check that the patients have bathed pre-op. The second recommendation has to do with surgical hand preparation. Do we use alcohol-based hand rubs or do we do hand washing? According to the proponents of AHBR in the WHO guidelines, there's only one reason why AHBR is now considered equal to the routine hand washing that you all know of, and that is, in Africa, there is no water. Mahal ang tubig sa Africa. So it's more expensive to do hand scrubbing than to use your alcohol-based hand rub. So we always tell the surgeons, you only do either because they're equal. You don't do your hand scrubbing and then use the alcohol-based hand after. You're just going to increase your risk for dermatitis and dry hands. The third is the skin preparation with alcohol-based antiseptic solution. Both WHO and CDC recommend alcohol-based antiseptic solution. This is CHG with alcohol or povidone iodine with alcohol. Unfortunately, DOH still does not have it in the national drug formulary. So I could not even request it because if it's not available in your drug formula, PNDF, you cannot procure it in a government hospital. So I asked, and of course, chlorhexidine is not allowed, cannot be used when you operate on mucosa. Okay. So, and of course on the eye, still use iodine. So we were talking about this with our colleagues in the infection control, and the recommendation now is if you cannot buy or if you don't have access to an alcohol-based antiseptic solution, the other way that you can do it is use povidone iodine first, just the antiseptic, and then wipe off with alcohol. It will have the same result. Fourth is mechanical bowel preparation plus oral antibiotics. Fifth is hair removal with clippers, so no razors. Surgeons are very mahilig mag-MacGyver. Okay? Kung hindi mo siya bibigyan ng razor, gagamitin niya yung surgical blade. Okay? So, we tell everybody, you don't even have to shave anymore. We used to do pubic shaving for appendectomy, but not anymore, even for hernia surgery. So, most of the surgeries that require hair removal now are neurosurgical procedures and gynecologic procedures. But the rest, very few will require removal of hair. Nasal decontamination for MRSA in high-risk patients, and the use of prophylactic antibiotics. More on that later. For wound care, antimicrobial sutures are conditionally recommended, use of triclosan impregnated sutures. We don't even have to use so much special wound dressings. If you just have a clean wound, closed primarily, you can just use the plain gauze and plaster. The only reason why we use those adhesive polyurethane, you know, the brands dressing, is because they're very convenient for the patient when they take a bath. Because nowadays, it's now taboo. We now recommend that you do not touch a wound. If it's clean, a clean wound, closed primarily, we recommend that you don't do daily dressing. The earliest time that you open it is 48 hours after, and you can ask your patient to take a bath already after 48 hours. Wound protectors are especially recommended for colonic surgery. So after coming up with the 2016 global guidelines, last March, WHO now came out with the implementation approaches for the evidence recommendations. Because it's so easy to read the guidelines, you don't know how to implement it. And I borrowed these 5 infographics for their preoperative. So you notice in the preoperative, it's the same. Take a bath, okay? Take a bath, use decolonization, do not remove patient's hair, and antimicrobial prophylaxis should be given. Okay, emphasis on the last, it's clean and prepare the OR. So see, it's not just the doctors who need to work. It's also the OR team, the people who work in the operating room have to make sure that the proper OR traffic, proper sterilization of equipment is performed. Otherwise, all our efforts will be for nil. For the intraoperative procedures, do not use laminar flow. It's not necessary anymore. So kawawa naman yung nagpagawa, ang mahal-mahal pa naman. Okay. Use either disposable. There's no recommendation. You can use disposable gowns. The nice thing about disposable gowns is you just throw them away. But definitely cloth gowns, as long as they're properly sterilized, laundered, is still okay. And the use of alcohol-based solutions. And consider using a warming device to promote normotherapy. And consider using a protocol for intensive blood, because blood transfusion is also a risk factor for surgical site infection. The last line there is to maintain asepsis and discipline in the operating room. Okay. And for the post-operative phase, do not prolong surgical antibiotic prophylaxis and administer oxygen in the post-operative period for the next 6 hours. So I think we have a little more time for antimicrobial prophylaxis. The guidelines came out in 2016 and 2017. But the choice really depends on the institutional antibiogram. So those guidelines were really a suggestion to everyone. The problem is I don't think the compliance rate is still very high. I saw the posters. Okay? And usually the timing of the giving or administration of the prophylactic agent is the one that is a logistic problem. We don't know if it should be given at the floors, in the ward, in the room, by the OR nurse, by the scrub nurse, or by the anesthesiologist. Because in JCI hospitals, it has been established that to be able to give it within the 60-minute period before cutting, it is actually the anesthesiologist is in the best position to give the antibiotics. So we really have to collaborate with our anesthesiologists so that the timing of administration can be adhered to. There's no need for antibiotic wound irrigation and no need for antimicrobial wound sealants. Okay. For the surgeon, staff, and factors, okay, gentleness in handling tissues. When you're not gentle, when you're brusco with your tissues, you create devitalization of tissues, and that can promote surgical site infection. Judicious use of drains. As much as possible, if drains are not necessary, you should not be used. And if they're not draining anything, it should be taken out. Okay? Minimize surgery duration. Ito na ang inyong reason para sabihin, Doc, wag masyado kang matagal mag-opera. Kasi pag nakabuyang-yang ang tiyan ko ng matagal, dumapasok lahat ang mga germs sa aking tiyan at sugat. Okay? Use PPEs. Ask your anesthesiologist to wear their gown, to wear their cap, wear masks, and not under the nose. Okay? Observe proper OR attire and traffic. Main problems, particularly with teaching hospitals, there are many student nurses, student doctors, and Filipinos being very social people, you keep on transferring from one room to the other, keeping the door open. The doors should be closed. Limit the number of people in the OR. So signages will help in your operating rooms. And ensure, of course, the sterilization of the equipment. So SSI surveillance programs are based on procedure, specialty, and surgeon. Okay? So your OR personnel, the environment of the OR, and the practices even in the PACU, or the recovery room, are very important. They should be monitored. Even our CICU and other surgical wards should be monitored. And the rates of compliance with process measures should continually be observed and reviewed to the surgical staff, personnel, and of course the leadership of administration. We cannot stress enough that the leadership has to be involved, because if you just keep on saying this, your OR nurse keeps on saying yes, one of your infectious disease specialists keeps on talking about SSIs, but the leadership does not support your efforts, again, sayang lahat ng efforts natin. So our challenges are, one, we have to engage all the stakeholders. And when we say stakeholders, I include the patient's participation. Patients now preoperatively, while in the clinics, are being told to take a bath before surgery, to make sure that they have no acne, no active infection elsewhere before surgery, to minimize the risk of surgical site infections. Okay? We need institutional support. I'm so happy with DOH that there is the imprimatur from them to do antimicrobial stewardship and to monitor and report SSIs. We also have to monitor and feedback using our infection control nurses in infection surveillance, and of course standardize the process, because we have to make sure that everybody is doing the right thing. If we keep on doing things differently, it is very hard to come up with meaningful data. So with that, thank you very much.
Thank you to all our speakers for the very informative session that we had. We actually still have time for some questions, so the floor is open for questions for any of our speakers. There are 2 microphones at the center. So while we're waiting for those, we just want to summarize. No, we heard 3 different lectures. Dr. Kwek first walked us through some novel approaches in CLABSI. We presented several evidences. She presented the risk factors for central line bloodstream infections, including intrinsic and extrinsic factors. She also presented the need to present all areas of care, or to prevent CLABSI in all areas of care, including the insertion of the catheters, the maintenance of the catheters, the removal of the catheters. She highlighted the importance of clean hands. So all throughout, if you heard the lectures, clean hands, hand washing, using proper PPEs, the choice of an optimal site for the catheter insertion. She talked about, or she stressed also, the need to properly disinfect the hubs using chlorhexidine disinfectants, and the need also for line necessity surveillance. for our CLABSI. Dr. Rojas discussed with us the whys and whos of MDROs. She talked to us about the global, the different risk factors for MDROs, which included repeated contact with healthcare, within the healthcare system. She talked about the two most powerful ways to prevent MDRO transmissions, which is through the hand hygiene and the cleaning of reusable medical equipment. And she walked us through the 7 steps of infection prevention and control for MDROs, if you recall that. And then, of course, lastly, Dr. Saguil discussed to us different manners by which surgical site infections may be prevented, even something so simple as the frequency of changes of the dressings of these surgical sites to prevent infection or contamination of these sites. So are there any questions for our speakers from the audience? Tan, Ma'am Vicky. Natanong na kasi ni Vicky. Okay, Dr. Ma'am Vicky will ask. Earlier she was asking kasi. Okay.
Actually, everything is there in the lecture, but it's a matter again of how we implement, especially on the those patients colonized or having infected with the MDRs. So our problem is now on the good practice of the contact precaution, especially on the use of gown. In the use of gown, it should be like a single-use gown, but the gown is washable. And it is now a problem with those with limited resources. Also the practice of hand hygiene and the use of gloves. We often observe the use of glove is not in front of the patient. Many are wearing their gloves, touching the doorknobs and other highly touched surfaces before touching the patient. But they wear the gloves, they do the hand hygiene, but it is not at the point of care. So ito yung mga nagiging problema natin every time we are on a practice of contact precautions.
Siguro, I don't know if Dr. Eva might want to have some comments on that, no? Because part of the 7 section mentions the surveillance and the proper donning.
May direct po ba ako mag-Vicky? Sige po. So as said by Ma'am Vicky, when you wear your gloves for contact precautions, so do hand hygiene before and after wearing the gloves. Yes, tama po yun. And then, use of gowns na. So ideally, it should be one use lang, no? Kung baby, bawal magtambay yung gown. So that's the ideal. However, we all know some facilities might not be, cannot support that practice. So, paano bang gagawin? So, mabibigyan din naman. So, paano pag gano'n? Baliktad. However, yun nga, ideally, the gown should be one use lang, but in actual situation when it can't be practiced, okay, so you can still, pwede naman ilabhan yung gowns, di ba?
I think a big factor is, one thing that Dr. Rojas stressed earlier in her presentation also was that the very basic hand hygiene. Again, you'll never tire of hearing this because Ms. Vicky was saying there's a break sometimes in the practice of donning the PPEs, but when it comes to hand hygiene, Dr. Rojas mentioned that proper hand hygiene can actually prevent as much as 40% of HAIs, no? And that's a big number as far as managing our patients and our epidemiology in the hospital. No? Are there any more questions from the audience? We still have time for one more question. Maraming nanginginig, giniginaw. Okay. So anyway, at this point, we'd like to call our distinguished speakers so that we can award their certificates of appreciation. I don't know, is Dr. Alejandria here or Dr. Mario? None.
So while our speakers are going up the stage, may I remind everyone to please accomplish the evaluation forms on your MECA app before you get your certificates of attendance.
So our session, Symposium 8, has been concluded. This will be followed by lunch symposia, but I think there's still time. So if you want to visit the exhibits as well, you may do so. Thank you for your attention.